Good morning. Topic for discussion is management of discolored tooth. The contents include classification of discoloration, bleaching, contraindications for bleaching, bleaching agents, classification for bleaching techniques, and effects of bleaching on tooth. Classification of discoloration. The stains can be classified as intrinsic stains as well as extrinsic stains. In the intrinsic stains, there are pre-eruptive causes and post-eruptive causes. The pre-eruptive causes, the disease include alkaptonuria, hematological disorders, disease of enamel and dentin, and liver diseases. The medications which can cause stains are tetracycline stains and antibiotic use, also fluorosis stains. Post-eruptive causes include pulpal changes, trauma, dentin hypercalcifications, dental caries, restorative materials and operative procedures, functional and parafunctional habits, and aging. Extrinsic stains, daily acquired stains due to plaque, food and beverages, tobacco use, poor oral hygiene, swimmer's calculus, gingival hemorrhage. Chemicals include chlorhexidine as well as metallic stains. Classification of extrinsic dental stain. According to Matthew, it can be classified as N1, N2, and N3. N1 is a direct dental stain, N2 is a direct dental stain, and N3 is an indirect dental stain. Classification of now, what are these N1, N2, and N3? N1, NATU1 is actually the chromogen binding to tooth surface and causes discoloration. The N2 is a chromogen color changes after binding to the teeth, and N3 is a pre-chromogen binds to the tooth and causes a chemical reaction to cause a stain. Now, what are the different metals which causes stains? Copper dust will get a green stain, iron dust will get a brown stain, mercury gives a greenish black stain, nickel green stain, and silver black stain. Now, intrinsic stains, we have already discussed the pre-eruptive causes. The alkaptonuria causes dark brown pigmentation of primary teeth. It's an autosomal recessive disorder resulting into the complete oxidation of tyrosine and phenylalanine. Hematological disorders include erythroblastosis fetalis, which gives green, brown, or bluish color. Congenital porphyria gives red or brownish discoloration. Sickle cell anemia stain is similar to erythroblastosis fetalis. Now, what are the diseases of enamel and dentin? Developmental defects in enamel formation, amylogenesis imperfecta, fluorosis, vitamin and mineral deficiency, chromosomal anomalies, inherited diseases, tetracycline, and metabolic disorders. Now, amylogenesis imperfecta can be due to hypocalcified enamel, hypoplastic pitted enamel, and hypomaturation of enamel. Fluorosis staining manifests as green or white opaque areas on tooth, yellow to brown discoloration on a smooth enamel surface, moderate and severe changes showing pitting and brownish discoloration, severely corroded appearance with a dark brown discoloration. Defects in dentin formation, it can be dendrogenesis imperfecta, erythropoietic porphyria, tetracycline and minocycline stains, as well as hyperbilirubinemia. Dendrogenesis imperfecta causes grey to brownish violet to yellowish brown. Then tetracycline stain, according to Jordan and Broxman, can be classified as first degree tetracycline stain, second degree tetracycline stain, third degree as well as fourth degree tetracycline stain. Other post-eruptive causes include pulpal necrosis, trauma, as well as dentin hypercalcification. Now, coming to dental caries, then restorative materials and dental procedures, aging related changes in enamel changes as well as dentin changes, and also functional as well as parafunctional habits. Extrinsic stains are daily acquired stains include plaque, food and beverages, poor oral hygiene, swimmer's calculus, gingival hemorrhage, chemicals, as well as metallic stains. Types of tetracycline stain. Core tetracycline causes grey-brown stain. Dimethyl chlorotetracycline causes yellow stain. Doxycycline does not cause any staining. Oxytetracycline causes yellow stain, and tetracycline causes yellow stain. Coming to bleaching. Bleaching is a procedure which involves the lightening of color of a tooth through the application of a chemical agent to oxidize the organic pigmentation in the tooth. Now, what are contraindications of bleaching? One is poor case selection, then dentin hypersensitivity, extensively restored teeth, teeth with hypoplastic marks and cracks, defective and leaky restoration. Then bleaching agents include hydrogen peroxide, carbamide peroxide, and sodium perborate. Hydrogen peroxide, it is actually 5 and 35%. low molecular weight as well as releases oxygen, clear, colorless, odorless liquid. It's unstable, shelf life is about 3 to 4 months, used alone or in combination with sodium perborate. Sodium perborate is a white powder in granular form. Sodium perborate decomposes into monohydrate, trihydrate as well as tetrahydrate. When mixed with superoxide, it decomposes into sodium metaborate, water and oxygen. Carbamide peroxide, it is also known as urea hydrogen peroxide, which is about 3 to 45%, decomposes into urea, ammonia, carbon dioxide and hydrogen peroxide. Carbapol is added along to prolong the release of active peroxide. For gel preparation, glycerin, propylene glycol, sodium cyanide, citric acid and flavoring agents are used. Now coming to the bleaching techniques, there are vital as well as non-vital technique. For vital teeth, home bleaching technique or night guard bleaching technique is used. In-office, thermocatalytic, non-thermocatalytic as well as microabrasion. For non-vital teeth, we have thermocatalytic in-office bleaching, walking bleach or intracoronal bleach, inside-outside bleach, closed chamber bleaching or extracoronal bleaching as well as laser-assisted bleaching. Home bleaching or night guard bleaching, it was introduced by Haywood and Heyman in the year 1989. Factors that guide the prognosis for home bleaching are sensitive teeth, dark gingival of the tooth, extensive white spot, translucent teeth, excessive gingival recession and exposed root surface. Commonly used solution are 10% carbamide peroxide, 15% carbamide peroxide, hydrogen peroxide in the concentration 1 to 10%. Indications are mild generalized staining, age-related discoloration, mild fluorosis, acquired superficial staining, staining from smoking tobacco. Contraindications are insufficient enamel, surface cracks and fracture lines, defective restorations, severe fluorosis, large anterior restoration, fracture or malaligned teeth, extreme sensitivity as well as white spots. Now steps for tray fabrication are, we take the impression and make a stone model, then we trim the model and apply the separating media, then we choose a tray sheet material that is ethyl vinyl acetate. Now then we do the vacuum, cast the plastic in vacuum tray forming machine. We'll get the model, trim and polish the tray, check for the fit of the tray. Now these are different images. You can see the first image, you have the impression being taken, cast is poured and separating media is applied. Then we actually do the vacuum formation, and then we actually get the material. We actually trim and finish the material, seat it in the patient's oral cavity. Then we demonstrate the patient what all things has to be done and what are the instructions that have to be followed. Then coming to the thickness of the tray, standard tray is of thickness about 0.035 inch. Thicker tray is 0.05 inch and thinner tray is 0.02 inch. Then side effects are gingival irritation, soft tissue irritation, altered taste sensation as well as tooth sensitivity. Now the advantages include, it's a very simple method, simple for the dentist to monitor, less chairside time and cost effective. Whereas the disadvantages are patient compliance is mandatory, color changes depend on the amount of time the tray is worn as well as there are chances of abuse. Now in-office bleaching, thermocatalytic vital tooth bleaching, the equipment needed are power bleach material, tissue protector, activating source, protective eyewear. Light source used are conventional bleaching light, tungsten halogen light that is 40 to 60 seconds per tooth, xenon plasma arc that is about 3 seconds per tooth, argon and carbon dioxide laser that is about 10 seconds per tooth, and diode laser that is about 3 to 5 seconds. Indications of in-office bleaching are superficial stains, moderate to mild stains. Contraindications are tetracycline, extensive restorations, severe discolorations, extensive caries, patient sensitive to bleaching agents. Now coming to the procedure, pumice the teeth, isolation and protection, bleaching agent is applied. Then we have to change the bleaching agent after every 4 and 5 minutes. Treatment time should not exceed more than 30 minutes. Now we remove the solution and irrigate and polish and apply neutral sodium fluoride gel. Now we instruct the patient to use the fluoride rinse, and second and third appointment is given after 3 to 6 weeks. Coming to the advantages, it requires less time, the overall time than the home bleaching technique. Patient motivation is there, and also protection of soft tissues. Then disadvantages, more chair side, more expensive, unpredictable as well as deterioration of color is quicker. dehydration of the teeth, and discomfort of